Sir, we are in live. Good to go.
Sumit sir, you are mute. You are muted, so you have to unmute. Sumit sir, yeah.
Yeah. Hi. Good evening, everybody. And at the outset, I would like to thank everybody who is online to be present here for this live neurology update on tremors. So the first issue in the tremors aspect is that there was a joke by Winston Churchill, who used to say that between Parkinson's disease and Alzheimer's disease, what would you choose? So he would used to say that I would prefer to have Parkinson's disease because I would like to be having at least half a bottle of wine in my hands rather than actually forgetting what is the place where I have kept the bottle. So I think tremor is at least something which we can do something about as compared to other things and the field of movement disorders in neurology. And there is always a misconception in the minds of people where they think that Alzheimer's disease and Parkinson's disease is actually the same thing. And therefore, it is worthwhile not only clearing the minds of people about the concepts of tremors of different types, how do you classify them, how do you treat them, and are there any recent advances in the management of the Parkinson's disease? So on this aspect, I would first like to invite Dr. L.K. Prashant from Bengaluru, who has been a very dear friend of mine for several years and is a renowned movement disorder specialist. And I would like to take the first talk from him, where he would be introducing us to the concepts of the classification of tremors, because there has been a sea of change in the classification of movement disorders. Dr. Prashant, can you kindly start?
Thank you, Sumit. I hope my slides are ready.
Yeah.
Thanks, Sumit. Thanks for inviting me for this important session on tremors classification, and definitely thanks for INTAS to taking lead on having this approach to tremors and management of tremors. What I'm going to talk is going to give a preamble which Rishi and then Shivam are going to talk about in detail. The point is there have been various tremor definitions over a period of time. Things are changing every decade when we look into tremors classification. Currently, when you look into tremors, we just classify them as, tremors are defined as tremor is an involuntary rhythmic oscillatory movement of a body part. Probably this is the definition what we are going to use when we talk about tremor as of now. The tremors, when you look into it, that when you want to approach a tremor, when you want to classify a tremor, the things have been changing dramatically over a period of time. Over many years, people have used various concepts to define tremors or to classify tremors. This could be phenomenology based, this could be frequency based, or most of the commonly it was a syndromic based. That was what in 1998 the MDS tremor group came up with a syndromic based diagnosis. This was easier at that point of time because we knew that which tremors fits into which part, which type of classification, and it has its own advantages because there was a syndromic approach to it. However, there was a lot of drawbacks also to that, because when you put a label to it, some certain type of tremors cannot be just one isolated type of a tremor. It can be associated with other type of movements also. What we are trying to do is we are putting both pathology and etiology together. So that's the reason recently in 2018, the Task Force on Tremor of the IPMDS, that is International Parkinson Disease and Movement Disorders Society, had a big consensus statement about how to classify the tremors. For today's talk, I'm just going to stick to this so that it's easy for anyone, for a novice, to understand what is the current classification of tremors and how tremors are approached or classified. Yes, this paper per se has its own set of limitations, its own sets of critics, and its own modifications down the time, which I'm not going to address in this talk. So let us say, as a novice, if you're a resident or if you're a general practitioner about this, then you will know that how the tremors are being classified and how we are going to approach these things. So what this classification based upon? What they have done is, now they have taken about all those disease syndrome based approaches and they have done the tremor classification into two separate axes. One is axis 1, what they call it as, which is based upon clinical features, and axis 2, which is based upon the etiology, means what is the underlying question. This is what you can remember in dystonia. This is what you remember in various other syndromic diagnoses or in psychiatric disorders. We all go by this type of a classification. But the most important question what comes to our brain is why we should go to this type of a classification. That is what comes to our brain. I hope my videos are not overlapping there. So why this type of classification is required? Why need to we have a clinical based, is axis 1 and axis 2 based on a classification of tremors? So what they tell is, this is commonly used in most of the epidemiological studies. This helps to have proper approach where one axis gives you clinical syndrome and another axis gives you etiology. There may be intermingling or overlapping. A certain set of clinical features may have different etiologies and different etiologies may have a common clinical features. This have an advantage in understanding what is the clinical syndrome and what is the etiological diagnosis on this. So it also helps us to get more consistency across disorders for research. Let us say when we have a different diseases to compare down the time, the standardization of classifications will help us to have little bit of a cross-table matching of these things. So that is why this newer tremor-based classification has come forward. So what does this tell? What does this have? So if you look into axis 1 is based upon basically clinical features, which has historical features, the tremor characteristics, any associated signs, and additional lab-based pictures. So lab also comes under the clinical feature here. So that's what you need to remember here. So what we look at historical features, this is based upon our clinical history, how the tremor started, when did it start slow, did it start acutely, subacutely, or has it been slowly progressing over a period of time? What was the past medical history? Was there any history of jaundice, head trauma, drug exposures? Is there family history is there? How does this tremors respond to various stimulants like alcohol or drug sensitivity? So these looks into the historical features of the tremors. Then we look into the tremor characteristics here. This includes body distribution, like you have isolated hand tremors, you only have one part of the body, like single hand tremors you have, isolated hand tremors, or a tongue tremor what you have, or you may have segmental, means in a certain segment or two contiguous segments are involved, like both the hands are involved, head and hand is involved, neck and hand is involved. So these are called as segmental tremors. Or you may have hemibody tremors. You have one half of the body which is involved only, which is called as hemibody tremor. Or you may have generalized tremors where your upper body and lower body is involved to have tremors. Then we look into various activation conditions, where how the tremors are present, whether the tremors are present only at rest, are they present with posture or movements. Previously, we had tremors were classified as rest tremors, postural tremors, and action tremors. Now we are classified into rest tremors and action tremors, where in that we have this kinetic tremors and postural tremors. So these are different ways which has been added up here to look into activation conditions, to look what are the different activation methods where how these tremors act or how do they behavior in different activation conditions. Then we look into the tremor frequency. This is where we look into whether this is more of a neurophysiological diagnosis, where the tremors is of a lower frequency, where we call less than 4 Hertz, 4 to 8 Hertz is a medium frequency, 8 to 12 is a physiological tremor, and more than 12 is a high frequency tremor. That's what you need to remember as well. Then whether tremor is an isolated symptom or whether tremor is associated with other symptoms or signs, which can be in the form of signs of systemic illnesses or like for example, systemic, let us say as in Wilson disease associated with jaundice, there is K-Fring, there is icterus is there. So this gives an idea about that. Or patients have other neurological signs like they have rigidity, they have slowness, or they have dystonic posturing of the limbs, or they have some other associated soft signs like mild tandem impaired, minimal cognitive impairment. So these things we look into it to see that whether there is an associated signs are there, based upon that whether we can classify them. Then, as usual, we have the lab-based, which includes electrophysiological, structural imaging, receptor-based imaging, and serum and tissue biopsy. So this is what the Axis 1 covers up. So this is what we should remember when we look into the Axis 1 classification of the tremors. Then we have Axis 2, which primarily looks at the etiological causes, means what is the underlying cause for the tremors as such. This could be various neurodegenerative disorders or genetic disorders, chromosomal aneuploidies like XXY, XXYY, XXY. And this could be then there could be infectious or inflammatory disorders, neuropathies, SMAs, drugs, toxins, and many others. So this includes all plethora of possible underlying causes, including unknown. Probably we can put it here as a etiological causes. Based upon these two, we are going to classify all tremors, and that is how our diagnosis will happen. In addition, what has been done is because a lot of the clinical syndromes, what has been there in Axis 1, many of the diseases are present concomitantly. So we know them when this is there, there's no need to tell it as an isolated tremor. There is no need to tell it just segmental tremor. We know a diagnosis. We know what it means. So the consensus statement, the group has decided to keep what we call it as the tremor syndrome. So this helps us to understand where we fit in. This is other part of this classification where they have brought it forward. So what they have done here is in the tremor syndromes, they have this action and rest tremors. In this, we have essential tremors and ET+, isolated segmental tremors, isolated rest tremors, enhanced physiological tremors. Then we have focal tremors where you just have voice tremors, head tremors, many people coming with head tremors, jaw tremors, face or other limbs, or essential palatal tremors. People can have just a task specific or a position specific tremor, such as only you notice tremors when writing, when playing certain sports, when playing certain musical instruments or activities, which we call it as a task specific tremors. Then patients may have tremor with predominant other additional neurological signs, such as dystonia, Parkinsonism, intention as in cerebellar, Holmes, myasthenia, symptomatic palatal tremors are the part of the other tremor syndromes. Then you have orthostatic tremors, where you have primary orthostatic tremors. Primary orthostatic tremors are the tremors where it's a very high frequency tremors, postural tremors, usually more than 13 hertz, 13 or above hertz. Pseudo-orthostatic tremor are once again orthostatic tremors, most of them associated with other underlying secondary causes, but many times the frequency can be lesser than 13 hertz. That's what we need to keep in mind. Then we have others, which includes functional tremors and the indeterminate. This is where the new term has been brought forward, because I think indeterminate has where we don't know how to classify it. I think specifically it applies to the essential tremors. It has come such a situation now, it's very difficult. It has become for us to tell any diagnosis as essential tremors because of the strictness what they're looking into essential tremors, looking into dystonic posturing of the hands. So probably it has become very slippery slope for any one of us to tell any patient with tremor as convincingly as just as ET, which is a very difficult task at this point of time based upon where you are talking. So that is where this is coming forward. So based upon these things, I'm going to show few of the videos of different tremors just to get an idea of this, how this syndrome classifications have been used forward. So I've tried to use this Axis 1 and Axis 2, so just to get some idea. So this person has presented with history of tremors of the hand, usually noticed when he stretches his hand, when he's active. So he started to have tremors in his early adulthood. So tremors are classified based upon age group also. You have infancy, that is from birth to 2 years, childhood from 2 to 14 years, 14 years, 2 to 13 years, 14 to 18 years as adolescence, 20 as adolescence, then you have 20 to 45 as early adulthood, 45 to 60 as mid-adulthood, and more than 60 it is late adulthood. So that's what you need to remember. So this person presented with early adulthood tremors, only had both upper limb or segmental tremors, and he was noticed to have hyperthyroidism. So this is an enhanced physiological tremor. Associated underlying etiology was due to endocrine or metabolic disorder as such. So this is other patient who started to have tremors in axis 1. You look in adolescent onset, who is around 15 to 16 years of age, which in primarily both the hands were having. In addition, she was having dystonic posturing with stretched out hands. It was much more prominent, with MRI showing various signal changes, which was suggestive of Wilson disease. So this is a dystonic tremors, which is noticed in Wilson disease patients. Then this is a patient who had recently had GB syndrome and recovered from GB syndrome. And after that, as soon as he recovered, he started to notice that he was having tremors of the hands. These are upper limb tremors, primarily that is segmental tremors, and which are noticed morely on outstretched hand, even on slightly on rest, they were noticed intermittently. There was no other associated clinical signs other than this tremors. So this may fit into a peripheral nerve or peripheral tremors, what this patient is having. Then this is another patient who presented with history of difficulty in writing. Whenever he starts writing, he notices his shaking of the hand. Other than that, he is able to perform all the tasks without any problem. And it's only task specific, which is primarily noticed when writing. So without any other underlying etiology. So axis 1 is early adulthood, task specific or position specific tremors noted down writing. Clinical syndrome wise, we call it as primary writing tremors. Then this is a person who presented with middle adulthood with isolated hand tremors. Usually on the left hand, you can notice that it was noticed primarily at rest. There was associated history of stiffness, there was slowness, and because of this, he is having a Parkinson's tremor, which is in the axis 2. So this is how the classification moves on in the Parkinsonian tremors. This is a lady who had come with history of difficult, feeling uncomfortable while standing. You can notice that she's able to stand, but she's very fragile in her balance. She feels she can't stand. She's going to fall down. That is what she is having. What she is having is a orthostatic tremor. Basically, orthostatic tremors are difficult to see. Most of the diagnosis is based upon palpation. What we see on auscultation, we saw the helicopter sign or helicopter humming type of a sound. And people electrophysiological, they have a high frequency tremor. So there will be no other associated clinical symptom. This is what is the orthostatic tremor looks like. Then we have pseudo-orthostatic tremors, where people have orthostatic tremors when they stand, but associated with there may be other signs and they may be higher frequency. Here you can see that you can notice that there is a tremulous sensation. You can notice she is having a wobbling movement along with that. She has this primary lower body tremors, lower limb tremors noted while standing, and MRI was showing significant myelopathic changes. So this was primarily degenerative or structural changes related, probably put under a criteria of pseudo-orthostatic tremors. Then this is palatal tremor. There are two videos which are there running. One is essential palatal tremors, another is functional palatal tremors. I'm trying to see, I can play the second video. Yeah. So these are isolated palatal tremors, what you can notice. And other than this fits into a classification of isolated tremors, where only the palates are involved. And there may be a symptomatic palatal tremors, essential palatal tremors, or palatal tremors with progressive ataxia. There are different types of palatal tremors are there. Probably this is for just for a videographic observation of various types of palatal tremors, what I'm trying to show here. Then previously this we would have called it as Holmes tremor or cerebellar outflow tremors. Now this fits into an axis where we call it as a middle adulthood onset tremors, hemi-body tremors, wherein action tremors are more than postural and the rest. Primarily, you can see that he has more of intention when he's trying to move the hands. Intention tremors are the tremors where the frequency of tremors dramatically changes when they go near or go to a position to meet, when the change in the posture happens. And this patient had presented with recurrent vomiting with significant MRI signal changes, which are suggestive of a Wernicke-Korsakoff syndrome here. So this is what which fits into a intention tremors or cerebellar outflow tremors here. Then the always, which we shouldn't never forget, is the functional tremors, which is can present in any age group. This lady presented with middle adulthood. You can notice that variable frequencies of tremors, which is distractible, and definitely there is a history of stress, episodically occurring with acute onset of symptoms and just getting better with just behavioral therapies and other supportive measures. So these are all functional tremor syndromes, what we call it as. So this lady presented with difficulty in speaking, and which started to notice in the later part. She was very much concerned that she was not able to speak well. Her children were not able to hear her voice, which she classified under as a late adulthood isolated voice tremors. So that's what it meant. She was trying to tell that people on the phone not able to understand that. So another case with axis late adulthood, basically isolated tongue tremors started after started taking levosulpride. Okay, and this is a drug-induced or a toxin-induced isolated tongue tremors. What you can notice down there.
5 seconds, don't move it.
Similarly, one more early adulthood, had cirrhosis of liver, underwent liver transplantation. She was admitted, she was receiving cyclosporin, and when she started receiving cyclosporin, she developed acute severe tremors. So this was a drug or toxin-induced tremors which improved following withdrawal of the precipitating drug. And then finally, the slippery slope, which I'm not going to talk about, is this tremor. The patient starting to have middle adulthood onset tremors, both upper limb tremors, action more than postural, no rest tremors, strong family history. Tremors are present only for last 2 years. So currently for a diagnosis of essential tremors, it is required that tremors should be there at least for 3 years. It should be present in the both upper limbs, and no isolated head, voice, or neck tremors are taken as part of the essential tremors. So that's what we need to keep in mind. So these syndromes, whether they are essential tremors, whether they have associated dystonia, calling it dystonic tremors, or there are associated other set of symptoms, making them to classify under other disturbance, which only time can tell here. So those were just a glance of how different types of tremors look like and how the current classification helps us to look into it. So how to approach those tremors? So if you look into it, they are very simple. When you look into it, we look into electrophysiological tests to understand the frequency of the tremors. Any other associated signs are there. Look for structural imaging, tissue and biomarkers for metabolic blood testing, like for Wilson disease or hyperthyroidism or electrolyte imbalances, genetic tests. Then we have research. This is what the 4 crux which is required for evaluation of tremors. And evaluation of what is the frequency, what is the severity of the tremors is done based upon various tremor evaluation scales, which includes physiological scales such as accelerometer, EMG, computer drawing, subjective scales which include spiral and handwriting based, objective scales includes water pouring test, 9-hole pegboard test, MAGE test, and definitely most important is quality of life at the end of how the disability scales and handicap scales are. So based upon this, there are various treatment options, which I'm not going to cover. I think Shivam is going to cover it down the time. And how does this respond? Because many times when you look into it, tremors are very severe set of symptoms, and symptoms progress dramatically over a period of time. And many of these tremors are easily treatable and they significantly respond to the diet. You can see here, this is a patient who had tremors for last 20 years, and this tremors dramatically responded to levodopa. So this is where medications helps to improve the tremors as such. This was a person who was not able to even hold a glass and comfortably holding the glass on the right-hand side video as against the left-hand side video. You can notice that in a couple of seconds. So this is what I wanted to highlight here, how he was not able to even hold a glass, now holding a paper glass and drinking the water. Then always you have a stroke of luck, I'll tell. But here there is a, I'm hoping I'm waiting for my slide to move forward. Okay, fine. This is called as lucky demyelination. This person had severe tremors, almost grade 4 tremors. He was in the medical profession, and he had decided we have long-standing grade 4, not able to do anything. I don't have the initial video of his. And then in between, he had planned for surgery for him. And then finally, he told he'll come back and get it done. During this tenure, he had acute ADM with demyelinating plaques across the brain, multiple plaques. And following that, there was significant improvement in tremors. The person was not able to hold the pen, not able to do anything. There was significant reduction in his tremor. Now was able to do much more activities. This is probably what we call it as a lucky demyelination or a lucky strokes many times what we look into it. And finally, the DBS-based treatment for tremors, which we know that DBS is a well-established therapy for management of tremors as such. And this is a patient who had tremor-dominant young onset Parkinson disease, in whom he has underwent DBS after 12 or 13 years of Parkinson disease. And you can notice that how his tremors dramatically vanish with a click of a button for his tremors as such. With this, I'll end my talk here, and further talks probably where Rishi is going to cover up and Shivam is going to cover up on various aspects on different types of tremors and its management. Thank you. Thanks a lot.
Thanks, Dr. Prashant, for those lovely talk. And I'm really sorry that I could not introduce you properly because my screen was not working. So this is the introduction for Dr. Prashant. Is my screen visible?
Yeah.
Hello?
Yes, sir. Yes, sir.
Yeah.
Is my screen visible?
Absolutely, sir. Yes, sir.
Okay. So Dr. Prashant is a specialist in Parkinson's disease and other movement disorders at Vikram Hospitals in Bengaluru in Karnataka. He is a founder member of the Movement Disorder Society of India and the web editor for the Movement Disorder Society of India. He's on the editorial board of Moving Along newsletters of IPMDS. He's on the editorial boards of International Parkinson's and Movement Disorder Society website. He's an executive committee member of the Movement Disorder Society of India from 2014 to 2018, and he's going to be again there for probably the next session as well. He's a member of, Membership and Public Relations Committee of the IPMDS, and he's the member of the MDS Regional Task Force on the Movement Disorders in Asia, apart from his several contributions in the academics as papers and his research projects. So thank you, Dr. Prashant, for an excellent presentation. And may I now request Dr. Rishikesh to kindly take over and present his talk on the management of what I would call as non-essential tremors. And it would be my proud privilege to introduce Dr. Rishikesh Kumar. My screen is visible?
Yes, sir. Yes, sir.
Okay, so Dr. Rishikesh, his most important qualification is that he is one of a very, very dear friend of mine. And apart from that, he is known across the country and the world as a very, very renowned movement disorder specialist from India. He is currently the head of the Department Neurology and in charge of the Parkinson's Disease and Movement Disorders Program, and the director of RGCM Research Center and vice chairman of the Institute of Neurosciences at Kolkata. He is a member of the executive committee and treasurer of the Movement Disorder Society of India. He is going to be promoted soon. A member education committee and Movement Disorder Society of the AOS. He is the founder president of this Parkinson's Disease Patient Welfare Society of Kolkata and the Spinocerebellar Ataxia Type 12 Consortium. He has been awarded by the Vishisht Chikitsa Samman from the government of West Bengal in 2019. selected for the Indian Academy of Neurology Queen Square Fellowship in 2006 to 2007. He received the Patricia Harris Award in 2006 and 7. His present research interests are great studies in different Parkinsonian syndromes using gait-right electronic walkway, mechanism of freezing of gait, a neurophysiology of movement disorders, and has several publications in national and international journals. And it is very, very difficult to have an appointment with him. So I have to actually request him to see some of my patients whom I refer to him. So he's an extremely busy clinician apart from all these things. So Dr. Rishikesh, may I kindly request you to present your talk on the non-essential tremor treatment.
Thank you, sir. Thank you very much. That was very kind. But the most important part of the first line, and rest was rubbish.
It was not anyway, but
that the most important part is I'm your close friend, and I consider you as a close friend, and I hope that this will keep on going for decades to come. All right, I'll start now. Slide visible and sound visible, right, Prashant?
Yes, sir. Yes, sir.
Perfect.
All well, all well.
All right, sir. Thank you. So I'll talk on non-essential tremor. That's a very interesting topic, Dr. Sumit. Very interesting topic, because when you see the pun of the word, that it's not essential at all, right? So tell this guy that this tremor is trivial and a non-essential tremor, and we will get a slap. So when we call non-essential, that doesn't mean that it's not essential to treat. It's non-essential or essential as per the nomenclature. Moving on, how common is non-essential tremor? We all know that essential tremor is most common. 4 to 8% of people, they have general population, they have essential tremor. But when you see the non-essential tremor, Parkinson's disease, small number, 0.15%, cerebellar, very small number, dystonic, very small number, also small number. But when you sit in the clinic, you get more of non-essential tremor rather than essential tremor. The whole reason is that they bother people more. And when you see the numbers also, enhanced physiological tremor is non-essential tremor, and number is 9%. So it's not only by numbers, also by importance. This is very important. Non-essential is very important. I'll start with SC12 because that is the one non-essential tremor in my practice, and many people of the North India, even in Bangalore, that this we get more often as compared to any other non-essential tremor, and we get confused with essential tremor. So this is a case of postural tremor, action tremor, in young Agarwal, in about 45 years old Agarwal person, which kept on progressing to the extent that later on, it became very severe, and the patient had gait difficulty. So that is SC12, autosomal dominant inheritance. This polyglutamate disease, Agarwal population, late onset, slowly progressive, postural tremor, ataxia. They may have dystonia in Parkinsonism also in due course of time. So the learning point is that any patient with so-called essential tremor comes to your clinic with clear family history and Agarwal background, Agarwal population, think of SC12 first before essential tremor. And in SC12, the patient may have not only postural tremor, they can have rest tremor, they can have intentional tremor. You can see that the patient has a head tremor, also an intentional tremor. And when you see closely, some of the SC12 patient, they have Parkinsonism and dystonia as well. This patient in the right hand, in due course of time, you can see that slight rotation starts. The thumb is coming in. So dystonia, subtle dystonia is there in many patients of SC12. And we had a paper on that. And we could see that apart from tremor, this is tremor. Intentional tremor was most common. Rest tremor was also there. Postural tremor was also there. So this SC12 can look like anything. Can look like essential tremor, can look like dystonia, can look like Parkinsonism. Now, how to treat that? Unfortunately, we have not produced enough data. This onus is on us to produce data on SC12 treatment, but we have not done so. So what we do, we use the treatment for essential tremor in SC12 as well as propranolol, primidone, topiramate. And of course, primidone, we do use in some cases of SC12 also because postural tremor is quite common. But some patients, they have Parkinsonism and have used levodopa with gratifying benefit for at least few years. And the patient who have Parkinsonism, when you go for DAT scan, the limited study, I have 2 patients, and the limited studies also, that DAT scan may be abnormal. And those are the subgroup who respond to levodopa more as compared to others. They have been mention of DBS, no published publication, but mention of DBS. In one case of SC12 by Paresh Doshi, he wrote a commentary, and he wrote that in one patient he had done DBS, thalamic DBS, and he found that tremor was much better, but ataxia worsened. So DBS has some role in improving of tremor at the cost of ataxia. Moving on, Prashant showed a good video of orthostic tremor. This is isolated tremor on standing. Such a fine tremor that you cannot feel it. You cannot see it, but you can feel it only. You touch the feet and you can feel it. You can see the garment, it's moving. Apart from tremor, the patient has subjective unsteadiness during standing. When they stand up, they feel unsteady. When they start walking, 3-4 steps, they are unsteady, and after that, they get better. This gives an impression of start hesitation or freezing of gait in some cases. On surface EMG, there's 13 to 18 Hz tremor. It is slowly progressive. 1/3 of orthostic tremor patients, they have additional symptoms like mild ataxia, Parkinsonism, and very small number, they go on to develop Parkinsonism. This very short video, 3-4 seconds, but you see his shorts, you can see that movement of the short. You may not see the movement of his leg, but you can see the movement of his shorts. So it's so fine that you have to see the garment or you have to touch the patient's leg to feel the tremor. The treatment of the first line treatment of orthostic tremor is gabapentin and clonazepam. Those unresponsive to these 2 medications, very difficult to treat. Only 12% responded to alternative medication, and that includes primidone again, acetazolamide, levetiracetam, and in rare cases, they do respond to levodopa, but very, very rare. Generally, they don't respond to levodopa. There have been some reports of gabapentin. This is the only medication, as I told you, that gabapentin has the best evidence in this tremor, orthostic tremor, and it improves tremor. It improves gait imbalance also, what we see in the initial start hesitation. It improves quality of life. But the problem is that, you can see that in the figure that swaying also improved with gabapentin. The problem is that those studies were only 6 patients. Dose range was 600 to 2700 milligram per day. And you try giving your patient 27 milligram of gabapentin, they can't tolerate at all. So in Indian setting, that high dose is very, very difficult. And so practically, it's less effective on smaller dose. DBS has been used in isolated cases. There's no big study, only 1 or 2 patients of DBS here and there. And they have shown very clearly that on WIM DBS, there was some improvement. A is baseline, B is off stage, and C is on stage. In this picture, you may not perceive it, but on frequency spectrum, you can see that the tremor has improved. And the subjective improvement was also there. Coming to another non-essential tremor, palatal tremor syndrome. There's a nice article which came only recently. One of my friend, Shakya Bhattacharya, has published it. Nice review of palatal tremor. We all know that pathology or pathophysiology is in the Guillain-Barré triangle. And this is one of my case of palatal tremor. This can be essential where cause is not known. Ear clicks may be heard in those. Ear clicks, you can also hear the ear clicks. Secondary palatal tremor, usually MR is abnormal. And third is PAPT, progressive ataxia with palatal tremor syndrome. This is related to Paul-G mutation. And of course, psychogenic is also very common. It seems unlikely that patient will produce psychogenic, but about 50% of cases of palatal tremor, they are psychogenic. Treatment of true palatal tremor, clonazepam, gabapentin, carbamazepine, phenytoin, valproate. Now, what will happen that in all tremors, similar set of medication will come. Some are more effective, some are less effective, some are not effective, but similar set. Clonazepam is used everywhere. Gabapentin is used everywhere. So these medications have been used, but no big studies. There are single case or 2 cases of various medications. In my practice and in some literature also, toxin works very well in palatal tremor. Botulinum toxin, essential palatal tremor, it works very well. This is a paper on review of toxins, and you can see that they have collected all the cases, including Pramod Pal's cases. They 8 cases. Patient was 8 years old. And in all patients, they either resolved or some improvement was there. So the message is that in palatal tremor, botulinum toxin is quite important, and it helps. If we decide to go for botulinum toxin, It is very easy. You have to give medial to pterygoid hamulus. There is a projection near pterygoid hamulus. You have to give medial to it. You can decide into two sites. The red is 7 units and the blue is 3 units. It's very easy. Just put the tongue depression and you'll find it. There's the anterior fold of just in front of a uvula. It's difficult to see intraorally, but I just wanted to give the flavor. That projection on the lateral side is pterygoid hamulus, just medial to it, two sites, small dose, 10 units or maybe 5 units, and patient, it works well. So that's a botulinum toxin for parietal tremor, and this patient is doing very well, and she's receiving for last 2 years or so. Coming to cerebellar tremor syndrome, any cerebral pathology, what we saw in SCO12, any cerebellar pathology can cause tremor. It's common in multiple sclerosis. Typically, they have postural or kinetic tremor. The medications we use, carbamazepine, propranolol, topiramate, primidone, isoniazid, ondansetron, 4-aminopyridine. I've written these medications as per the anecdotal reports, but many times nothing works. Again, the toxin, if the patient has limb tremor, which is more at wrist or more at elbow, this toxin works very well. And this is one of the study where double-blinded study, and they found that the tremor score, the writing score, and spiral, everything improved, and p-value was significant. So Botox has a role in tremors. Coming to Hope's tremor, thalamic tremor, Prashant has showed a good case that it's slow, very slow, 4 to 5 hours, combination of rest and internal tremor, and often postural tremor also. It's often less rhythmic than others. There can be jerky component. Levodopa has been tried, traxfendial have been tried, clonazepam, clozapine, levetiracetam. Out of this, first two, levodopa and traxfendial, may work in some cases. Again, toxin injection, but toxin injection is less effective. The reason is that the big muscles are involved, and that dose of toxin, and somehow it doesn't work. DBS has, in some cases, DBS has shown good response. There's a case, my case, having a large aneurysm that is coiled, that's PC aneurysm, and you can see that it's pressing the midbrain and substantia nigra. It also pressing the cerebellar outflow tract, and the patient developed Parkinson initially, and later on features like Holmes tremor. The patient went to Mumbai with Petrus and Dr. Paresh Doshi, and this is one of the rare case of Holmes tremor who received DBS, VIM DBS again. Tremor definitely improved. What has happened, I'm following this patient for last 1 year again, post-surgery. Tremor started to recur, but not to that degree. Still she can manage somehow, but her ataxia has worsened. So DBS, the problem is that tremor improves generally and ataxia may worsen. Moving on, if you have thalamic tremor, then thalamus is the site. It's very difficult to put the electrode there. In that case, you have to choose more than one site, including VIM, VOA nucleus, or sometimes GPI also. So you have to use more than one sites for stimulation. Now coming to tremors with element syndrome, one case of GBS was shown by Prashant that this is seen with inflammatory post-GBS, post-CIDP. Up to 80% of case of IgM protein neuropathy, they have tremor. Medications we use, again, propranolol and pregabalin. Out of them, pregabalin somehow works better. And there's a study about that also. Or if the neuropathy is treatable, like GB syndrome, like CIDP, treatment of neuropathy itself helps. If the patient is not responding to medication, then VIM stimulus or even thalamotomy, that works. In case of anterior horn cell disease, you may have mini polymyoclonus, which looks like tremor, but it has jerky character, and the amplitude is very, very small. So this is case of anterior horn cell disease, motor neuron disease. The previous was a case of GB syndrome, post-GB syndrome. So in case of peripheral nerve origin tremor, rhythmicity may be less. You may have more jerky component. Dystonic tremor, it's common, especially in the hand and head. It has jerky character. It is distinguished from other tremor by jerky character, null point, subtle underlying abnormal posturing. Like this patient of cervical dystonia, when you see him, you can see suddenly it jerks in no direction. So it's not continuous, it's not rhythmic, It has jerky character. And when you see very closely, his left SCM is hypertrophied and is touching his chin so that the tremor improves. That's just antagonist to your sensory tree. This is a case of focal hand dystonia, task specific, but you can see tremor is very prominent. So this is again dystonic tremor. Tremor and dystonia in the same body part. In all such tremor, you can try using triaxphenidil, but unfortunately it doesn't work. The main treatment will remain the botulinum toxin. Over here, head tremor is very common in the sense that cervical dystonia is common. And any case of head tremor, if you know that splenic capitis, ingestion of splenic capitis, both sides, the tremor improves significantly. Splenic capitis, the landmark is below the menstrual process, below and behind the menstrual process, about 1 centimeter. And it's very easy to reach there. And I think everybody can inject. Now, some dystonic tremor, this patient has PCAN, NBIA, and you can see that dystonia is so pronounced and tremor is there. Jerky character is still there. This patient did not respond to medication. This patient did not respond to Botox also. And then she underwent DBS. She underwent DBS under Mohit Bhatt in cochlear vein. And you can see that dystonia is still there, but tremor is less pronounced as compared to the previous one. Okay, tremor. Parkinson's disease itself is a non-essential tremor, and we all know about the treatment. It can have rest tremor, typical rest tremor. It can have what we call as re-emergence tremor. You see in this video, re-emergence, rest tremor, outer stressed, tremor goes to come back again. But there's misconception that patient will have only rest tremor. You can see in this video, the postural tremor, action tremor is so pronounced. The principle of treatment remains the same as we saw in one video of Dr. Prashant, that levodopa responsive. Give levodopa. Small dose of levodopa may not work. In fact, small dose of levodopa may worsen tremor, because what happens that small dose of levodopa, it reduces rigidity, it reduces bradykinesia, and tremor may become more pronounced. Fortunately, tremor-dominant Parkinson's disease, they can tolerate higher dose of levodopa to the tune of 200 milligram 3-4 times a day, and then patient tremor responds well. Apart from Parkinson's treatment, she once published a nice paper of botulinum toxin Parkinson's disease tremor. So those patients who has pronounced tremor, rather than increasing the dose of levodopa, only tremor is symptom, we can go for botulinum toxin treatment, and in a few years it can buy for you. One of my mentor, Dr. Mandar Jog, he published a paper on, again, tremor of upper limb treated by botulinum toxin, but using some kinematics. And he showed that it was better than using through EMG. Enhanced physical tremor, this is just enhanced tremor what everybody has. It's visible postural and action tremor, 8 to 12 hertz, little faster. About 10% of people over 50 years, they have tremor. It's either central or peripheral, reflex loop activation or central oscillator. This can be seen in a lot of conditions. I have put 3 or 4 conditions: anxiety, fatigue, hyperthyroidism, alcohol, drugs, and you name, or many medications can do that. Many metabolic conditions can do that, like hypocalcemia, hypercalcemia, even hyponatremia can do this. So this is fine tremor, distal tremor, fast, 8 to 12 hertz. Psychogenic, this most common form of all functional movement disorders. You see the tremor and you'll know that it's sudden onset, remarkable variation. It keeps on varying. Entrainment, distractibility, I'll show one video afterwards. Co-contraction. Most important, you see the patient. She looks to be in pain. No organic tremor will cause so much of pain, right? She feels that she has a lot of pain. And generally that doesn't happen with organic tremor. So this is psychogenic tremor. This patient has psychogenic tremor. And upon distraction, he's counting backward. As soon as I start to count backward, thus now art start, the tremor is gone, and it takes the rhythm of his counting. So this is classical psychogenic tremor. And as we discussed in palatal tremor, that many times palatal tremor can be psychogenic. This psychogenic palatal tremor, where rhythm is not uniform. And apart from that, this also has co-activation. You ask the patient to tap finger, and you can see that the palatal tremor, that takes the frequency of a finger. So I'll finish that. Yes, some patients may not have essential tremor, but essential for them to get rid of it, essential for us to help them out. So this patient will never say that it's not essential to treat. And thank you much. Thank you.
Thanks, Dr. Rishikesh, for a fantastic presentation and a display of several types. Am I permitted to show a couple of videos?
Sure, sir. We love it.
Can you allow me to share my screen, please?
I've stopped.
So, as has been rightly pointed out, there are several issues which one has to see. Can you see this? Is the screen visible? Is my screen visible?
Screen visible, but video is not coming till now.
Okay.
Screen is visible. There are multiple icons, small icons here.
Is it visible now?
Prashant, I can see.
The video is not shared. Only the folder you have shared. I think you need to share the video specifically.
Share the
I don't
desktop.
know why is it not visible.
It is not playing here.
Yeah.
I don't know.
We can see that it is levosulfide induced tremors, but it's not playing.
You have to click on the sharing the desktop.
Yeah, that's what I did. I don't know why. Let me see if it works out again.
I think you can stop sharing and reshare it wherever the video is playing.
It did once.
Yeah.
Still, it's not the same.
So I have clicked on share screen. Then I clicked on the folder. Then I clicked on the file. And it is
Then it will
playing.
not
But
work. It will not
Do
work
one thing. First play the
video
and then share the screen.
with that video. Stop sharing
Play the video now and
on yourself.
visible now?
Yes.
yes,
Visible now?
Yes.
yes, sir, yes, sir.
Is it visible now?
Absolutely, sir. Visible, sir. Visible.
Yeah. So this is another very important cause of tremors, which is drug-induced tremors. And this was a patient with levosulfuride who developed this acute tremor-like response in a matter of 2 weeks after levosulfuride was started. And this patient had a dramatic response after the medicine was stopped.
I think the levosulfide now it's one of the commonest causes of
Yes,
drug-induced
that's what I
tremor.
wanted to highlight.
You remember, I also showed just an isolated, just tongue tremor was the cause for the levosulfide. The
Yes,
patient
yes.
because you don't know how levosulfide. People decide that then they shouldn't tell that they are using levosulfide. Other than that, every other druggist they will tell other than the levosulfide.
Then sometimes you can have
Wrist clonus. Nice one to see.
sometimes you can have something which resembles tremors, but it is not actually a tremor, like this patient. So he has a left-sided weakness, and when you examine him, he has this tremor-like situation, which is actually a clonus.
Yes.
Which develops as a recovery point from a patient with stroke. And this wrist clonus is a spontaneous thing which happens when you touch the patient. So this is another thing which one has to keep in mind.
This is very.
And then finally, post-stroke, you can have tremors. Just a second.
Saying of that clonus, we had one in that video card. I remember it was Soham's case.
Yes,
Nicely
yes.
presented. On the video, it's very, because when you examine, you have a lot of other clinical cues for you to make. On the video, when you show it, you don't know the cause of it. That was
Yes.
one of the, I remember, very good cases of Soham where you had presented.
Yeah, exactly. So this is the final video which I would like to share. And in 30, I think. So this is a patient with the stroke. And the only problem he's having is the tremor, which he feels when he starts to write. Now, you'll be surprised to know that in this particular case, the lesion was in the cingulate gyrus. He did not have any language problem. He did not have any other deficit, and the only point he developed was tremors while he was writing. So you can have varied manifestations of tremors with varying pathologies. And so now I think for the last component of this evening, may I request Dr. Shivamom Mittal to present his talk on the management of the essential tremors and the advances in that particular field. And may I take this opportunity to introduce Dr. Shivamom Mittal, who is currently at the Cleveland Clinic, Abu Dhabi. Is my screen visible?
Yes.
Okay, so he's at the Cleveland Clinic, Abu Dhabi, at the Neurology Institute, and he is the section head of the movement disorders section and a consultant staff neurologist at the Cleveland Clinic, Abu Dhabi, UAE. He was a consultant neurologist, Parkinson's disease and movement disorder specialist at the Vikram Hospital and Columbia Asia Hospitals at Bengaluru in India. And he is a board certified neurologist with fellowship in Parkinson's disease and movement disorders. We all know him very well for his exemplary work on tremors. And therefore, when I was approached for a talk on tremors, his name was the first one which came to my mind. So Dr. Shivam, kindly take it over and tell us everything about the advances in the management of essential tremors.
Thank you, Dr. Sumit. Thank you, everybody. I'll share my screen here. So my topic is advances in treatment of essential tremor, and I've given this task to finish in 20 minutes. So I'll try my level best to finish this big topic. The objectives will be to talk about medical treatment, brief overview of botulinum toxin treatment, and then surgical interventions and what new do we have for the patients with essential tremor. Dr. Prashant already went through the classification, but this is very important to classify ET versus ET plus tremor. And we know essential tremor is isolated tremor. We have to have a diagnosis of 3 years at least without any subtle signs of dystonia or any problem with tandem gait or any finger-to-nose ataxia. So it should be very isolated, just the tremor in the upper limbs, mostly action and postural tremor. So the number of ET, pure ET, is actually will be far less compared to what we had previously. And now we'll be seeing more of ET plus. But again, we'll see how things go. And this is a very good review article by the evidence-based review by the MDS committee, mostly reviewing all the treatment options for essential tremor. We are familiar with the medicine propranolol, and this has been used for many years now. And we are all using this medicine all the time for our essential tremor patients. And there's a strong evidence for it. More than like 13 level 1 studies have been published with over 255 patients. And we usually start with the dose of, depending on the age and other medical issues, starting with 10 milligrams, 20 milligrams, gradually going up. In the studies, most of the studies were done in US or UK, and the patient population is quite different from what we see in India. And for some reason, I realized that people in India and Asian population, they do not tolerate that high doses that people in US or UK tolerate. So in US and UK in the studies, they have been to high doses of 240 to 360 milligram of propranolol, and they found significant improvement in the clinical rating scales, task performance, ADLs, patient global impression of change. Now, the most common side effects that we see with propranolol is bradycardia. And clinically, when the patient comes to the clinic, we do have to check the heart rate. We have to check the blood pressure in lying down and standing, checking for orthostatics, making sure they're not symptomatically lightheaded, because we know that propranolol can cause hypotension. So all these things have to be addressed. But very commonly in the studies, bradycardia and bronchospasm, the most common side effects. Coming to primidone, there's another very strong medicine we have for essential tremor with level 1-8 studies published with more than 274 patients. Again, we start with a very small dose. Unfortunately, in India, we didn't have the small dose of primidone. So, but in US, we used the 50 milligrams primidone, start with half tablet and then gradually increase. Now I'm glad that we will have now in India the small dose of primidone as well. So we don't have to go 1/8 of 250 milligram of primidone, and we can actually start with 50 milligram and titrate the dose accordingly. So primidone is a very good medicine for essential tremor, has been well proven for with good long-term efficacy. The good thing about this medicine is absence of tolerance for the therapeutic effect. Patients have a good effect for several years. In a head-to-head comparison study between propranolol and primidone, they found that patients preferred primidone than propranolol. But the problem with primidone was with the initial dose titration, the patients may experience side effects. So you have to go very slow, starting at a small dose and gradually increase on a weekly basis. And the most often we see the side effects at a dose of 62.5 milligram per day, bothersome side effects such as dizziness, weakness, tiredness, unsteadiness, sleepiness. These are the most common side effects. And very commonly, the patients would have a feeling of a toxic reaction, which usually occurs at a smaller dose when you're starting the medicine, if it's going to happen. But once the patient, if the patient is doing well with no issues, usually you can go up to higher doses, and the patient have a very good tolerability, and they find the tremor is under better control with primidone. Now, the adverse events which led to discontinuation in the studies ranged from 7.5% to 40%. And this again depends on overall medical comorbidities of the patient, how old is the patient. Is a younger patient will tolerate it better. Older population might not do that well with the higher doses of primidone. Combination of primidone and propranolol has been associated with greater benefit in postural limb tremor than monotherapy, but in that study, the safety and tolerability was not reported. The third medicine that actually has good evidence is topiramate, and there are a total of 4 studies, which are level 1 studies with over 322 patients with essential tremor. The major drawback of topiramate is all the studies, the dose that they used, the effective dose, was actually more than 200 milligrams per day. And we have a lot of experience with topiramate in migraine and epilepsy. And we know that patients at more than 100 milligram or 150 milligram, Indian patients more so, they experience side effects. And I think that's a major drawback that we experience in Indian population. For some reason, US population, UK population, they do very well. They do not have a lot of side effects. And that's why the studies are promising, where we see topiramate, even at the dose of more than 200 milligram, the patients did quite well. And it really improved the tremor amplitude and activities of daily living. The most common side effect of topiramate, as we all know from our experience in migraine and epilepsy, it can cause paresthesia, tingling sensation around the fingertips, causes like a zombie feeling, like concentration and attention. Appetite suppression can help in weight loss and things. Now, there are many other medicines which have been studied. We don't have enough evidence or strong evidence because not dedicated studies have been performed to look at each and individual drug. We know, as I have highlighted, topiramate, propranolol, primidone, alprazolam in some studies have found to be helpful, but again, we know the potential for abuse for alprazolam and the side effects, most in elderly population, leading to falls with benzodiazepine use. So its clinical use is limited. This is again, in clinical practice, we use gabapentin as well, but there's not enough evidence. We don't have good quality studies on gabapentin. Then botulinum toxin has been helpful. There have been, I'll come to that in the next slide. And so as per the MDS, this review article, they did not take the recent study that was published. This review article was, they did the studies prior to the study that we published on botulinum toxin. And based on the previous studies, they found it was likely efficacious. So with the new study, I think the level should be upgraded. So it will be more efficacious, but we definitely need more evidence for that. So just to help, what is the usual doses of medications that we would see some benefit from medications? So the three most commonly used medications we use for essential tremor is propranolol, primidone, and topiramate. Other medicines that can be considered is clonazepam, gabapentin. But again, for primidone, it's very important to go slow, and very important to tell the patient that don't stop the medicine abruptly. That can lead to withdrawal, seizures, and I usually ask them not to take the medicine and go on for driving, or go to at least take it over the weekend to see how the tolerability is and how you're doing. It's a very long-acting medicine, so we have to see how the patient is doing with primidone. Now coming to the second section of my talk, which is botulinum toxin injection for essential tremor. This is the figure that we recently submitted to a paper in a journal under a review. This is on the right side, you can see all the randomized double-blind placebo-controlled studies, and on the left side, you see all the open-label studies. This is how we have progressed, or we have evolved in the field of botulinum toxin treatment in essential hand tremor and Parkinson's disease tremor. All the yellows are Parkinson's tremor only. All the reds are essential tremor, and blue are like an open label mixed bag of patients from essential tremor and Parkinson's tremor. And you can see that on the right side, you see the first two studies were on essential tremor by Dr. Jankovic and Dr. Brin. And the third one was done in 2018 by us at Yale. And all three studies were quite had a good improvement in tremor, and we have evolved. We have improved ourselves in a technique. Dr. Joe Grove from Canada, they have done several studies with the kinematics. On the left side, you can see the kinematic analysis, series of publications with a large number of patient population with excellent results with the kinematic analysis. So this is just a summary slide for essential tremor. And how do we inject for essential tremor? So this is for the previous approach by the authors from 2001, 1986, long time ago, where they injected a fixed dose, fixed muscles, and we experienced significant problems with that. Patient had a lot of side effects, mostly wrist drop, finger drop, and the tremor was better, but at the cost of hand weakness, which was not helpful. So we designed this study and published in 2018, where we had a Yale technique using customized injection approach, using EMG guidance and clinical technique. And this was a technique where we inject multiple muscles in the hand, and it's a separate talk altogether, but I'm just going to touch upon this because this is one of the advances in the new treatment for essential tremor. But this is mostly going through multiple muscles in the arm, forearm, hand muscles, and trying to see if we can capture the tremor without causing side effects. And in our study, we found there was significant improvement in the tremor, in the action tremor, postural tremor, and the spirals. And only 20% patients had mild hand weakness, which was detected by the ergometer. And only one patient had moderate to severe weakness of wrist extensor. So significant, it was significantly low compared to 60% or 90% in the previous studies by Dr. Jankovic and Dr. Brin. A few patients from our study that we can see at baseline, we can see at 4 weeks and 8 weeks after botulinum toxin injection, how we can see a good improvement. And these all are refractory to medications or good candidates for DBS, but they decided to go for something in between, and that's where botulinum toxin can be helpful. Now coming to the third part, which is the surgical interventions. Now this is evolving field. We are learning more about this, and there are mostly 4 surgical options for patients with essential tremor. The first one is radiofrequency ablation, where the surgeons they insert a probe inside the brain, and the targeting in the VRM area in the thalamus, and burn the neurons in the selected area to create a focal lesion. It's like a thalamotomy using radio frequency ablation. Then the other one is deep brain stimulation. We all are very familiar with deep brain stimulation. It is inserting the electrodes in the brain in the VIM territory for essential tremor, and attaching to the battery in the chest, to the IPG, and the patient needs programming sessions to control the tremor. Third option is a gamma knife radiosurgery, where ionizing radiations are transmitted through the skull. So there is no burr hole, and there's a permanent lesion. So we are giving radiations to the area in the thalamus to make a specific lesion. Then the latest one, the new kid on the block, is the MRI guided focused ultrasound, which is FDA approved treatment as well, where ultrasound waves are transmitted through intact skull to create a lesion. So all are thalamotomies except for deep brain stimulation, which is a stimulation treatment and not a lesional treatment. Now, going through the anatomy of thalamus, we know there are multiple nuclei, and it is very important to know the anatomy of the thalamus and the connections. We are targeting the VIM. Let me get my laser pointer. So this is the VIM we are looking at, and because that's the kinesthetic cell or the tremor cell that causes the tremor, we can modulate the activity in the cerebrothalamic tract to control the tremor. Radiofrequency ablation, we have to locate on the based on imaging and heat up that probe and make a lesion in the area of the thalamus. Gamma knife radiosurgery, mostly for patients who are at high risk of morbidity and mortality from surgical procedures, elderly patients who are on anticoagulation therapy. We cannot do any burr hole, cannot get anesthesia. For these patients, gamma knife is an option. I will come to the comparisons in next few slides between all these therapies, so we have a better understanding. And as we discussed, there's ionizing radiations which are transmitted through the intact skull. Now you can see in this in the slide, on the top right corner, we see that there's a lesion. There's a hyper intense lesion in the thalamus, which is a lesion made by the radio frequency. And here on the right side, this is a normal response that we expect. Now, when you have less radiation, you can have hypo response. You see not much of changes in the thalamus in this slide. And sometimes you can see hyper response where you see too much of changes. And that's why how much dose are we giving of the radiation? The response is not immediate. The response is seen after months of the treatment. So this is something that has a high numbers of complications and adverse events. But again, it's a scalpel-less treatment, which is an option available. This is the review of literature for the same treatment. And okay, now we'll go to the MRI guided focus ultrasound. This is Dr. Elias and group at University of Virginia. They are the pioneers of this treatment. In 1958, they did the first study, and since then they have really mastered the technique. This was a randomized double-blind placebo-controlled study which was performed in 8 international sites and more than 70 patients. And we can see that significant improvement in the tremor scores compared to sham stimulation. I want to highlight here the most common side effects with the focus ultrasound is like 38% patients had paresthesias at onset, which improved to 14%, and the gait disbalance. So mostly paresthesias and gait disbalance was the most common side effect we noted with focus ultrasound treatment. Coming to deep brain stimulation, we already touched upon that. We see around 50 to 90% improvement in tremor scores. And this is how we have evolved in the field. We all know the process of deep brain stimulation. This is a patient that we had DBS. We did a DBS for at Cleveland Clinic. So you can see his prominent postural tremor, action tremor. He's holding the cup. And now we can see that with the intra-op stimulation, we can see a very good control of the tremor in his right hand. Another patient who has actually, it's not ET, it's tremor dominant Parkinson's, but I'll show you that the great response that we can see with DBS. So you can see the significant tremor in right hand at rest, at posture, with action. And this is post intubation. So he is concentrating. We don't see any rest tremor. Now I'll give him a cup to hold. And we can see he is holding it very nicely without any tremor. And that's the beauty of DBS. Everything, patient is awake. You can examine the patient. You know exactly you're on the right target. This is a study. This is a case published by Dr. Amar Patel from Yale with Dr. Open, and they have published a case report where the patient had ET plus. If you look at the tremor, the patient has dystonia in the left hand with features of action and postural tremor. So this is now will be an ET plus tremor. I'll come to the important part, which is the pouring of water, which is you can see. But his left side is much more than the right side, and they went for the right VIM stimulation. And you can see in the post-op after the DBS programming, still we see tremor in the right hand, which is mild, but left side is actually very well controlled. We don't see much. I'll come to that water part as well. I find pouring water is a very good test to look for the kinetic tremor, action tremor. Now, so we know even though it is ET plus, DBS still works. But again, if the patient has tandem issues or gait issues, then we know why these patients develop more side effects when we're doing the programming. Now, this is the same patient. Okay, so problem with DBS, I have just a few more slides and I'm done. I think I'll be finishing on time. The two more main caveats with the DBS are side effects, and number two is loss of benefit in the long run. And this is something that was looked up in 2001, where 40 months follow-up was done, and it was like, okay, this is great. We still see this great effect of DBS in essential tremor. And if you look at the amplitude and the settings at 3 months and 40 months, the current has not changed significantly, just 3.4 to 3.6. So patients were quite stable. This is a recent study published, which is a 10 years follow-up. And you can see with over the years, the effect of DBS goes away. This could be the disease progression or habituation. It's hard to prove. This is the VRM, programming, hardware complications. Now coming to which therapy to choose out of these 4 treatment, we have the greatest experience with DBS so far with more than 1,093 patients. When the symptoms are bilateral, DBS is the best bet because we don't have evidence for focus ultrasound or gamma knife or radiation frequency for bilateral tremor. So when it's bilateral, always we have to think about DBS. In DBS studies, overall quality of life significantly improved in DBS patients. And coming to side effects and adverse events, we know that whenever we're introducing a foreign object in the brain, like a probe for radiofrequency ablation or DBS, infections possibility is there. In gamma knife, we came to know about the hyper response or hypo response and the delayed radiation effect, which we don't know because we are not seeing any immediate effect after that. And permanent side effects. So with DBS is a reversible treatment. So that's always an advantage for DBS compared to other therapies. When do we consider other options? Mostly when patient cannot go for DBS because of exclusion criteria, which is pretty stringent criteria that we have to follow. And also the patient has significant psychiatric issues or medical comorbidities, cannot get anesthesia, then we have to think about the other treatment options. So take home message, and this is our team at Cleveland Clinic, and thank you for listening.
Thanks everybody for a great evening and a great information on the tremors update. So I think we have some questions from the observers. But before they have some questions, I have some questions of my own. So the first question is that what tests would you advise, Dr. Prashant, for a patient who comes to you with tremors in your OPD, and how would you clinically evaluate them?
Hi, Sumit. I think most of these tremors can occur due to various things. That's what the initial chart what I had shown in the approach. The tests are based upon the associated clinical features. Patient is having long-standing tremors, no other clinical signs are there, things are not changing dramatically over a period of time. No other clinical neurological signs are there, either systemic or soft signs. Probably there is no need to investigate the patient unless until patient is very anxious and you want to make sure that nothing else is missed out. If some person is presenting with subacute, acute, or recent onset of tremors or a new change in the pattern of tremors, then definitely will require imaging, metabolic screening. Need to look for endocrine workup, electrolyte imbalances. These things are required for any patient whom you suspected to have tremors, who have acute onset. And more importantly, drug history is very important. If there is suspicion of those drug history is there, based upon that, further workup is required. Probably with this, most of the time you do get the answers for what you're looking forward for. If not, then based upon that, if required, genetic testing and other workups are required. I usually go by standard is metabolic screening, which includes thyroid function tests, blood tests, imaging if required, and probably it is where I stop, put my full stop, unless until there is a clear-cut clinical indication on from my side where I suspect further workup is required, or in suspected high degree of family history. That's where I look into it. That's how I manage my tremor patients.
So where would you advise patients to go in for either a fluorodopa PET or a Tourette SPECT and PET scan?
I personally, I don't encourage most of my patients to undergo any of these tests, mainly because it doesn't make any therapeutic difference to me. Okay, that's how I look into it. So these tests, especially when you're functional testing, I keep it for people where patients are very anxious to know whether they have Parkinson's or do they have some biochemical deficiency or not. In those cases only, I suggest for a Tourette or a F-DOPA scan. Otherwise, my threshold to get the functional imaging is very high. So I just don't get it done unless until very much clear.
All right. Dr. Rishikesh, can I ask you a few questions?
Sure.
One would be, I think one of the most difficult tremors to control would be the Holmes tremors or the rubral tremors. What would be your diagnostic and treatment approach related to that?
Any Holmes tremor, when it comes to this, unlike essential tremor, there's more likelihood of having something underlying. So all cases of Holmes tremor should be investigated thoroughly. And the first investigation is MRI, because Holmes tremor, that means you are interrupting with the structural integrity of cerebellar outflow tract. So MRI is very important. MRI, thin cuts of brainstem is very important. And that gives answer in many cases. If MRI is normal, then we are in soup. Then it's very, very difficult. Then you can say that some case of Holmes-like tremor can be seen in essential tremor also. Holmes-like tremor can be seen in SCH12 also. Then family history comes into picture, and then we go for genetic studies. Regarding treatment, Holmes tremor is one of the difficult tremor to treat. As we discussed in the presentation, that Holmes tremor doesn't respond to beta blocker that well. In that case, Holmes tremor, because this is in the area of cerebellum and midbrain, in some cases they have responded to levodopa, and I do use levodopa in Holmes tremor quite frequently. If the patient has not responded to levodopa, then it's very difficult. You can keep on using various medications, but any central tremor or any proximal tremor, topiramate has some value as compared to beta blocker. So any head tremor or proximal tremor, I do use topiramate, and there's some small literature also. And after that, it's dicey. After that, I go for Botox injection for a particular muscle. You cannot treat whole Holmes tremor, but when you feel that this is adapting quite frequently, and quite significantly, then you can go pectoralis. That gives some solace, some relief to the patients. And of course, DBS, if you ask me, the DBS is one of the best option in Holmes tremor. Everybody may not go for it, but DBS is the best option in Holmes tremor if there's no underlying disorder there.
All right. And the second question is, how frequently do you see asymmetry in essential tremors and orthostatic tremors?
Okay, in orthostatic tremor, it's very rare in my experience, but in essential tremor, it's very common. Essential tremor, I would say that I won't quote the literature right now, but at least 25 to 30% cases, maybe more than that, they are asymmetrical. So many conditions where we general condition like essential tremor, SCA2L, they have asymmetry quite often. So
Yeah, so
asymmetry
that
is
is
not
what I
only
want.
only property of Parkinson's disease, can be seen anywhere.
Yeah, that is what I wanted to highlight, because many times people come with the diagnosis of Parkinson's disease only because of the asymmetry, whereas there are no other manifestation of asymmetrical bradykinesia or any
Yes.
slowness. And why I asked you about the orthostatic tremors was because I saw a patient today, an international patient who came to me from Iraq, who had classical orthostatic tremors, but they were absolutely
Yes.
unilateral.
It's
So it
very
is
rare.
still under
It's
investigation.
publishable.
I think when it comes to pseudo-orthostatic tremors, the etiologies are quite variable. So in
Yeah.
that case, asymmetry can be there. But overall, when you look at number of orthostatic tremors per se, what we see is very small percentage. So it's very
Yeah, so
difficult
I
to
saw
put
her only
numbers
today.
on that.
So, and it was a young girl, so a completely unusual permutation and combination. She's under investigation, and I think I'll keep you posted. So, Dr. Shivam, now may I request you to kindly tell us, between the various drugs available for the treatment of essential tremors, which would be your first choice and why?
So that's a very good question. So, it's the first medicine I always think about Inderol or propranolol versus primidone, and the main thing is availability. So if we have both these medicines available, because primidone it's like very difficult to take it in India. 250 milligram, you take 1/8. It is very cumbersome. They sometimes take half, and it can be a disaster. So if we have now the smaller dose, and it will be easier. If the heart rate is okay, if they have if they have a history of hypertension or history of migraines, then I would consider going for propranolol. And if I don't see any other reason, then I would go for primidone. But my first line will be always propranolol. And then if I don't see much benefit or partial benefit, even with a high dose, I may add primidone to it.
Yeah, so I think because you're working in a different part of the world, the information is that in India now, the lower versions of the doses are available, and we have 25 milligrams available with a couple of companies making them. So I think that part can be probably taken care of, because one problem with the primidone is always the sedation.
Mhm.
And when you actually break a 250 milligram tablet into 1/8, it practically is never breakable. So you basically, you don't even know how much dose you're going in.
Exactly.
What would be the role of gabapentin in the treatment of essential tremors?
So I have not used gabapentin in my practice, mostly, but I have seen patients who are taking gabapentin for other conditions, for neuropathic pain, and there have been few patients where actually when we decrease the medicine, say the patient, I'll give you an example, who had spine surgery for radiculopathy, was on gabapentin, but he also had prominent essential tremor. When he was on high dose of gabapentin, his actually tremor was good. After the surgery, when we tried to take off the gabapentin, we saw the tremor was coming back. So in those instances, I've seen it is helpful. And if you have prominent neuropathic pain, that's a good medicine to choose.
All right. So there, now I think I have extinguished my supply of questions, and I would now switch to questions which have been put forth by the observers and the viewers. So Dr. Sutikshan Vasudev has a question which is currently unrelated, but I think it's worth answering. And may I request Dr. Prashant to kindly answer it? A writer's cramp diagnosis and medicines for it. It is completely a different topic.
Okay.
It is actually a full CME. Actually, it's a full conference. But yes, I think you'll have to answer it in a nutshell, taking as little time as possible.
I'll take two words. Writer's cramp is dystonia as against tremors topic today. And it's difficult in writing. So you have cramp, a stiffness of the hand or fingers when you're writing. Other than that, there is no other difficulty in performing any other task. There may be mirror movements associated with that. So any type of dystonia where people will have difficulty in writing, you need to consider for a writer's grant. Medicine, currently probably the first choice of treatment remains botulinum toxin at this point of time. However, many people, we do try levodopa initially to begin. The standard line of treatment for all dystonias does apply here also, but based upon patient to patient, treatments are modified. As it fits under focal hand dystonias, botulinum toxin will be the first line of treatment at this point of time.
All right. Dr. Rishikesh, what would be the recording procedures for tremors in the OPD? Do you have specific tools, specific mechanisms by which you can record the tremors, like a tremorogram, or a specific protocol which you follow for evaluation of tremors? Is there a sort of, I think, measurement tool for the severity?
Yeah. This is a question by Dr. Praveen, and this is a very, very good question, Praveen. In OPD clinic, I don't measure tremors. But if we have to do some study, and if we have to involve patient, then of course tremor measurement is very important, and especially when you have to see the medications. In my lab, we are using two methods. One is EMG machine itself, surface EMG. So whatever EMG machine you have, in the needle portal, you can use a disc electrode. What you use in the NCV also. Put the electrode in agonist and antagonist, and when you go to the your laptop or computer, there is option of choosing surface EMG. So in EMG, you have to choose surface EMG. That's it, and put the disc electrode, and that will suffice. In some cases of orthostatic tremor, I have used needle EMG also. We ask the patient to stand up. We put the needle in the gastrocnemius and soleus and also the quadriceps. In a lot of EMG, they have two channels or four channels. So you can use accordingly. So EMG machine, whatever you have, is a good way to measure tremor. Apart from that, when you have to see the amplitude, for that accelerometer based any instrument works very well. And then you have to accelerometer is very cheap instrument. Either you ask IIT guy or anybody to make an accelerometer for you, that's hardly a few thousand rupees, or you can buy online. There are some companies who are selling accelerometer based instrument online. One more thing has come recently. You can download on your mobile. This app is there. You download that, and then your mobile works as accelerometer. So you keep the mobile in the hand, and it can work as accelerometer. So these 2-3 methods are there, for which most practical is EMG what you have, and then you can buy accelerometer.
Okay.
I have fantastic. A point here. Means Dr. Praveen has asked, how should we record tremors in OPD? It's just a perspective of seeing the question. I looked completely from a different angle. I thought that it was how to record in OPD, not in electrophysiology lab as such. So if Praveen meant the same way, what I have interpreted the question as, so there is a specific protocol how to record the tremors, what all things have to be recorded, how many seconds of face movements, how many seconds of close-up face movement, hands, different activation methods, different tasks, which is provided by the IPMDS. You can use that as a standard method of recording any of the tremors for recording on an OPD basis. That's or a documentation from the perspective of doing the spiral drawings, the straight and line, pouring the water, all those things could be there, if that is what he had meant as. So just covering up both ends in addition to the electrophysiology.
The next question is by Dr. Neeraj Gupta. Is there any role of magnesium threonate in Parkinson's tremor? Anybody can answer, but I think I should push this question to Shivam.
Yeah, Shivam.
No, you will answer the next question, sir.
Yeah.
I have not used magnesium threonate in Parkinson's tremor.
I have no clue what it is, very frankly.
What has happened is that last year, a paper came about magnesium threonate in rat model of Parkinson's disease. This can be given orally or injection, and it crosses the blood-brain barrier. And rat model, it has shown to improve some biomarkers for Parkinson's disease, including motor biomarkers as well as CSF synuclein biomarker. So the new thing in rat model right now, and it has not been used in human Parkinson's disease. Okay, but as happened that in last 30 years we have seen that many things came up. They were good in rat model, but when it come to human, it didn't work. So this is supposedly new neuroprotector being used in animals.
I think quite a few studies are going on so-called micronutrients, macronutrients, and classification on And some of them, they are trying to target whether by giving this supplementation, it's helping out. It's as good as telling that God only knows at this point of time.
Yeah. There's a group in Australia and China. They're working a lot on magnesium 3 units.
Okay. Then there's a question on deep brain stimulation, which I will take the liberty to answer if you have permission. First is the cost of deep brain stimulation. So there are two types of devices which are available for deep brain stimulation. First is a non-rechargeable device, and the second is a rechargeable device. So both these devices are imported, and they have a significant custom duty. Therefore, the device itself for the non-rechargeable costs about 7.5 lakh rupees, and the rechargeable device costs about 10 lakh rupees. The OT cost, the surgeon's fees, the anesthesia costs, the stay in the hospital is variable at different places. So I can tell about my center, where a non-rechargeable device with deep brain stimulation complete package would cost about 11.5 lakh rupees. And a complete package for a rechargeable device would be somewhere around 14 lakh rupees. I'm reasonably sure that the cost would be different in different parts of the country because of the prices in which are variable in terms of the hospital fees, the OT charges. But this would be roughly a ballpark figure. And then there's a question on the role of deep brain stimulation in isolated cervical dystonia, which is not responding to botulinum toxin. So I think that it is very unusual for cervical dystonia not to respond to botulinum toxin. If the person is not responding, then either the technique is at fault or the dose is at fault. Mostly people take the cervical dystonia as undertreated modality, and the amount of botulinum toxin used is quite low. Almost all patients would have a very significant response. But yes, if they're not responding, then yes, we have done about 5 cases of isolated cervical dystonia with deep brain stimulation, of which 3 had an exceptionally good result. One had a cervical dystonia with a cervicoaxial dystonia, fantastic response. 2 of the patients did not show much response. And the 5th patient, which we did, has been operated only 3 months ago. So after deep brain stimulation, you usually would have to wait for about 3 to 6 months before you say that a patient is not responding. So our experience is this much, and may I request others to kindly pitch in for their, feedbacks. Shivam?
Sure. So we did a review of literature on this cervical dystonia and DBS, and around 40% was the literature evidence that we know that 40% patient improvement will be there. At CCAD Cleveland Clinic, we have not done any cervical dystonia for DBS, but during my fellowship at Mayo, we had many patients and with very severe on the Yale tremor, score, and it was very very good improvement. But again, if you look at overall studies, around 40 to 50% improvement is what we are expecting.
Yeah. This is the final question which we would be taking for Dr. Prashant. What are the chances of a patient of essential tremors going on to develop, I think, Parkinson's disease at a later date? Sharply, are the literatures available in this direction?
I think
there's a typological error. I think he wants to know how many patients with ET would eventually go to Parkinson's disease.
Yeah. I think that recently there has been a publication on this, but as I tell you, there is no clarity on, first of all, now that I was talking about that previously, telling about a diagnosis of ET per se has become a slippery slope. No one wants to take a diagnosis on ET on a side, because with so much of the difficulties going on for the ET side. And then how many people will convert them into Parkinson's disease? There is a small percentage I'm just not able to recollect at this point of time from the bin, which has been published in the Movement Disorders Journal last year, I think so. I need to look into it, but can happen. But whether this is ET with independent Parkinson's disease or ET going on to Parkinson's disease, that's a different thing, because not many questions have been answered about how they are related to each other, but it is known concept that people with ET can also have Parkinson's disease down the time, or ET progressing down to Parkinson's disease down the time. So there is a clear-cut publications are also available in this respect. Rishi or Shivam, if you remember those numbers, any one of you can pitch in here.
So I remember like there's a 3 times higher risk for essential tremor patients to develop Parkinson's. I have to find the exact citation, but I think that's what I remember. That 3 times higher risk in any ET patient to develop Parkinson's disease. Dr. Rishikesh.
Yeah. There's a nice big review by Joe Jankovic and some Dr. Arjun Tarakar in tremor and hyperkinetic disorder regarding exactly the same thing, relation between the two. And they examined more than 1,000 patients of Parkinson's disease who had history of possible ET. And the final conclusion was that they were not convinced with the relationship. So it's very difficult to say that this percentage of patients will convert into it. The main reason they have written that for ET and on PD also, which are diagnosed in all over the world, there is no gold standard. So who knows the patient who was diagnosed as ET? They started with tremor, and later on, actually they were PD to start with, right? And moreover, ET is a common condition, and on the top of that, you can have Parkinson's disease, and those patients will go to clinic more as compared to only ET. Only
Yes.
ET will remain in periphery. But those patients who had ET for 20 years, develop Parkinson's, they will come to you. And I will bias that, yes, ET goes into Parkinson's disease. To answer the question, both are different pathology. And personally, I feel, and whatever literature I have, that it's very difficult to have a relation that this will be, I would say RBD, I will be more convinced that you will go to PD, but ET, I'm not convinced.
Yeah. So I think this is a time for us to, I think, wind this evening off. And I should personally thank Dr. Rishikesh and Dr. Prashant and Dr. Shivamam Mittal for being there with us for this excellent discussion on tremors. And I also thank Intas Pharmaceuticals for bringing in this opportunity so that we could interact. From the technical team, may I have a feedback as how many people were online for this event?
Sir, around 610 participants have registered participants have attended on the
Right.
platform, and 110 are the YouTube live who have watched on the YouTube live.
Okay, so I have not sort of misdiagnosed and misjudged my idea that we would be having around 600 plus people to listen to this event. Thank you very much, everybody. Have a safe evening and all the best for the coming days. Thank you very much.
Thank you.
And have a good night.
Thank you. Bye-bye.
Thank
So much. Thank you.
Chetil, we can stop the live streaming.
Thank you, sir.
Okay, we are leaving. Have a
Yes, sir. Yeah, good night, sir. Thank you very much, sir.
good night. Hemal, call me when you're free.
Thank you.
Yeah.
Shivam, see you. Bye-bye.
Good night, sir.
Thank you.
Good night, sir.
Nikhil,
Good night.
thank you.
Good night, sir.
Chetil, we can stop the live streaming.
Okay, sir.
Yeah, please. Sir.
Yes, sir.
So please confirm once it is stopped, live streaming.
और वीडियो का लिंक भेज देना चेतिल